Thank you for the introduction. Hello everyone, and welcome to my presentation about my doctoral thesis. As you heard, association between cognitive performance and rhythm in same-day ECGs in an AF population. This is an ongoing project, and I'm not done yet, so all results shown are going to be preliminary. Okay, so let's start with the background. As many of you already know, atrial fibrillation is the most common cardiac arrhythmia, especially among older patients. Previous studies have shown a strong association between atrial fibrillation and dementia and cognitive impairment. You can see the mechanisms behind this on this graph or on this figure on the right. However, I want to, in my study, look at the hemodynamic hypothesis more closely. As you can see, part of that hypothesis is that different factors such as beat-to-beat variability and/or decreased cardiac output during AF increase the chance of thromboembolic strokes and silent infarcts. I wanted to find out if there was a direct and acute effect of the resulting cerebral hyperperfusion, which could be measured through cognitive testing. So putting this into one sentence, my question is, does the presence of atrial fibrillation at the time of testing impact cognitive function? To answer this, I used data from the Swiss AF cohort. It is an ongoing multi-center prospective observational study with 2,415 patients with atrial fibrillation. These patients are above the age of 65 and received yearly in-person visits at baseline, years 1 to 4, and year 7 if possible. At these in-person visits, patients received a 5-minute ECG and cognitive testing, among other things. For my analysis, I included patients with an ECG in either sinus rhythm or atrial fibrillation, and they had to have a same-day complete cognitive testing at least one in-person visit. Patients with multiple visits were included as repeat measurements. That led us to 1,974 patients, and those patients had 2,821 sinus rhythm ECGs and 2,385 atrial fibrillation ECGs. So now I want to show you how we assessed cognitive function. In this Swiss AF cohort, every patient received every single one of the tests I'm going to show you now. The most commonly known one is the Montreal Cognitive Assessment, which combines different aspects of memory and cognitive function. Then there is the trail-making A and B tests, the digit symbol substitution test, and the semantic fluency test. I won't go into how all of these work due to time constraints. However, all these tests can be combined into a score called the Cognitive Construct Score, or short COCO. It was created in Basel and is a factor score using all neurocognitive tests that I just listed. So, just quickly to the baseline characteristics of this population. First off, you can see that the population was around 72 years old, mostly male, and had a relatively extensive educational background. BMI was around 27, which is slightly overweight, and the CHADS-VAS score was around 3. I divided the population into patients with clinically classified paroxysmal AF and non-paroxysmal, which encapsulates permanent and persistent AF. And as you can see, around 40% were in the paroxysmal group. This is, however, just the patient's clinical classification and not necessarily representative of the rhythm during study visit ECGs. So certain patients with permanent AF could also have sinus rhythm ECGs if they were wrongly classified. Lastly, I wanted to show the patient's cardiologic medication very shortly. As you would expect in an atrial fibrillation cohort, 90% were on oral anticoagulants, and 20% underwent antiarrhythmic drug therapy. So now to my main findings. I used a mixed effects linear regression model, I used two actually, to find a difference in cognitive performance between patients with the same-day sinus rhythm ECG or an atrial fibrillation ECG. The reason I chose a mixed effects model was to accommodate for the multiple repeat measurements in individual patients. The two models I created were a very simple first model correcting only for age, sex, and education, and a more complex one additionally adjusting for risk factors such as previous strokes or hypertension and other things. I won't go into all the cognitive tests in detail due to time constraints, but the two most relevant ones are the MoCA and the COCO. Important to know is that this isn't the classical MoCA that ranges between 0 and 30, but a standardized model, so the values are a bit different. As you can see here, for MoCA and COCO, the beta coefficient, which indicates the effect of sinus rhythm compared to atrial fibrillation on these scores, was very close to 0. And looking at the p-values, it also wasn't statistically significant. This indicates no correlation between cognitive performance and type of rhythm in same-day ECG. Now I want to briefly talk about the strengths and limitations of my study. There are several strengths of this. First, the sample size of around 5,000 data points is very large and consists of well-characterized patients. As we have detailed data on patients' characteristics and medical history, we were able to adjust for several potential confounders. Also, study personnel were trained to perform neurocognitive tests in a consistent way in order to ensure comparability and minimize performance bias. Now to potential limitations. Firstly, even though ECG and cognitive testing was done within a very short time frame, they weren't done simultaneously, which could maybe have been done via a Holter ECG or maybe even a smartwatch. So we can't for sure say what rhythm patients had during cognitive testing. Secondly, we don't have any information on cerebral perfusion during the patient's visit. Finally, I think it is safe to say that the evidence that I have found in my analysis so far indicates no association between cognitive performance and atrial fibrillation in same-day ECG. My project, however, as I said, is not done yet, and all results are preliminary. Also, there are subgroup analyses planned, and it is always possible for there to be better trends in more defined patient groups. Thank you for your attention.
Thank you very much. Are there questions from the audience? Did you record symptoms at time of the presentation that might have an impact on their performance? If I'm dyspneic with a heart rate of 160, maybe my performance on the cognitive testing might be worse.
We have just a very simple, it's the ERA score for atrial fibrillation, where they just say what cardiac symptoms they have, but it's not specific for the day that we ask them. So we ask a very general question. For a heart rate, for example, we have the heart rate, obviously, because we do a 5-minute ECG. And I'm actually going to adjust my model. It's already planned that I will correct also for heart rate. So, yeah.
Good. Salvatore?
Thank you very much. Very interesting data. Did you analyze also MoCA and the COCO score on the cutoff of a normal or let's say values that are similar for cognitive disorder? So did you analyze if there is any difference when you use the cutoff of cognitive the deterioration and the normal MoCA and COCO? Is there any difference? Did you analyze that?
Thank you for the question. This very good idea is on one of the subgroup analysis I have planned that I have sadly not done yet, but I will do that for sure. Thank you.
The question. Did you analyze if atrial fibrillation had an impact in the cognitive function of patients, or if the paroxysmal atrial fibrillation can impact in the cerebral function in the acute phase? I think it's different aspects, because patients who have paroxysmal atrial fibrillation, they have symptoms related to this, and they may have abnormalities. What did you really analyze with this study?
If I understood correctly, it's more of a question of if this was for the clinically classified or not. So in my analysis, I didn't really look at the classification of the patients. So if they were permanent or persistent or paroxysmal, I just looked at them as atrial fibrillation patients, and therefore it was always only acute. So I didn't even consider if they were patients with paroxysmal or not. I just looked at the same-day ECG and the cognitive performance.
Okay, thank you very much.